So again, welcome everyone. So my name is Katalin Gomez, and I work with the MIDAS cross-cutting team of the ARC Northwest Coast, so the Applied Research Collaboration. So I'm going to start sharing my slides. Today's event is an educational and networking event, and it was organized by the MIDAS cross-cutting team. And MIDAS stands for Methodological Innovation, Development, Adaptation, and Support. But in short, we basically provide methodological support to all the ARC Northwest Coast members who are interested in doing applied research. So the aim of today's event really is, we found out that a lot of people don't really know about these subgroups at all, or even if they do, they are not 100% sure what they do or what they can offer. So we thought it would be useful to kind of have an introductory event that you can also learn from, but also network with other individuals who are interested in kind of similar or the same field. So in today's event, we are going to tell you a little bit about the methodological topic areas that we are covering today, but also how these kind of subgroups work, how you can join them, and so on and so forth. So as I mentioned before, this is getting recorded, and the slides and the recording or the link to the recording will be made available to everyone. So I'll be sending out an email after the event or in the near future. So I'd like to take the opportunity here to thank all the subgroup leads in organizing this event and for volunteering their time and expertise to help us support all those who are trying to do research in this area or in this field. So in terms of who's present in today's event, so basically the MIDAS have established 10 different methodological subgroups, and today's event is focusing on 4 of these. So it was a collaboration between Behavioral Science subgroup, Implementation Science subgroup, Clinical Trial subgroup, and Complex Interventions. So we are going to be touching on the other subgroups as well, and there will be the opportunity to sign up with any of these subgroups, but these are the subgroups that have contributed to the development of today's event. And throughout the slides, I've put in QR codes and links that you will be able to use, obviously, once you get the slides. But Ayla, our admin, who's also helped me organize this event, is going to be putting these links into the chat. So just in case you wanted to access them now. So just to give you an overview of what we are going to be doing today. So first, I'm going to give you a very brief introduction on these methodological areas and how these different subgroups kind of link together, because although they have massive overlaps, but they do have some distinctive elements and unique aspects as well. So, and then this is going to kind of provide a theory behind subgroups, but then we have 2 research fellows from ARC Northeast North Cumbria who are here today to present a couple of their research projects to tell you or to show you how these methodological areas actually happen in practice. Then about halfway through the 2 hours, we're going to have a short break, a 10-minute break. And when we come back from the break, we're going to put you into breakout rooms. So each of the subgroups will have a breakout room, and you will have the opportunity to network with others in the area, ask your questions. If you have prepared a 1-minute presentation of your project or project idea, that will be the time to kind of tell us about it. And then I'm going to flag up a couple of useful things, subgroup event and an online resource. And then finally, we're going to tell you about how you can enjoy and join these subgroups. And then at the end, hopefully, we'll have some time for some more questions at the end, if you have any more general questions left. And we're going to be asking you to fill in a feedback survey for us if possible. So just in the interest of saving time, I thought I would I would skip the meetings all around because that's going to take up half of the session. But I thought it would be useful for you to know who's present today. So we've got a good variety of institutions and professional areas as well. So we've got academics and non-academics, experts, non-experts, public advisors. So it's a really good mix, which I think really well represents what subgroups are trying to do. What we are trying to do is have all these people who are interested in conducting applied research in these particular fields or areas to kind of come together, learn from each other, and network. So we have people from the University of Liverpool, University of Central Lancashire, Lancaster University, Edge Hill University. We've got public advisors on board as well. We've got a number of professional practitioners, so we've got different hospitals. We've got East Lancashire Hospitals, Alderhay Children's Hospital, Liverpool Women's Hospital. We've also got some local authority research practitioners from Lancashire City Council, or County Council, sorry, and then Blackburn with Darwen Borough Council, and someone from the Alzheimer's Society. So it's a really good mix of people. And I just wanted to say that some of you might be familiar with some of the content of today's event. So please bear with us. We just wanted to make sure that everyone can get something out of this event today. So I'm going to give you a really brief overview about these methodological subgroups and their topic areas. So you would have received already in an email some information about what the aim of these subgroups are and what the methodological areas are that they cover. But we thought it would be useful to use the NIHR MRC framework for the development and evaluation of complex interventions to kind of show you how these different methodological subgroups work or could work for you within your research project, and also how these are kind of interlinked, because there are, as I said, massive overlaps between them. And you'll see that, and especially in my opinion, you will be able to use different subgroups at the same time for different parts. So it doesn't necessarily mean that you have to be part of every single subgroup. So in my head or in my brain, the way I make sense of this, and you can think about this in different ways, but complex interventions for me are kind of the overarching idea here. Like if you can imagine it as a big tree, which is the complex interventions with a number of different branches, which would be the behavioral science subgroup, the clinical trials, and implementation science. And all of these different subgroups can kind of help you along the way when you're designing or developing and evaluating interventions. So according to this framework, basically there are different phases for the development and evaluation of interventions. So first of all, you want to either develop an intervention or identify an intervention and use it as it is, or maybe adopt it to your needs. And in order to develop interventions, you will need to base it on theory. You will need to know what content to put into that intervention. So the behavioral science subgroup is a really good place to go for this part. In terms of identifying intervention, you might want to do a systematic review or search for a systematic review that already exists. So we have an evidence synthesis subgroup and an information science subgroup that can help you in that area. Now, the rest of the phases are mainly about evaluation, really. So the second phase would be the assessment of the feasibility and acceptability of your intervention, and then designing your evaluation. So you would do a pilot or a feasibility study, and then, you could take it to a full trial. So in order to help you with this, we have the clinical trials subgroup, and they can help you with all aspects of trials. If you have a randomized control trial, for example, with recruitment, with randomization, allocation, blinding, all the different elements. And if you're doing a quantitative analysis, which you will be doing probably, then we have the medical statistics subgroup that can help you with that. And then part of the trial, or as part of the trial, you might be doing process evaluation that most of the time uses qualitative approaches. So we have a qualitative subgroup, and within your process evaluation, You can identify so basically in clinical trials, the first step is to identify effectiveness of your intervention, but based on this framework, what this promotes really is to move beyond that, so we can identify why, how, for whom, under what circumstances these interventions can work. So you're basically evaluating your processes as well. You're looking at fidelity, whether the intervention was planned or delivered as planned. You're looking at dose, contextual factors, and so on and so forth. And this brings you nicely to the implementation element, where the implementation science subgroup can help you with your efforts to increase the impact and uptake of your intervention that you've tested through the clinical trials. So, and then this kind of brings us back to the complex interventions as well, because complex interventions can help you identify those contextual factors that will have an impact on behavior change, but also at large on the effectiveness of your intervention, or the success or unsuccess of your intervention. And through these phases, there are 7 core elements that you have to consider. So we've talked about the context that complex interventions can help you, but even experts in the behavioral science subgroup or implementation science would be able to help you with this. Developing, refining, and retesting program theory, refining intervention, again, behavioral science, implementation science, but even the other subgroups can touch on this. In terms of engaging stakeholders, we have public involvement and engagement subgroup that you can make use of. And we also have a health economics subgroup that can help you with economic considerations, cost effectiveness, and so on and so forth. So if you would like to learn more about this framework, I've put in the link, the Skivington et al. To the Skivington et al. Paper, and Isla will be sharing that in the chat as well. So feel free to have a look. And another thing that I would like to quickly flag up is that the ARC in general is all about reducing health inequalities. So whatever research that is associated with the ARC is done, it has to consider health inequalities or health equity, and at the least to make sure that we don't increase health inequalities. But obviously, best case scenario would be reducing health inequalities, but not all projects aim. The main aim is for all projects is not necessarily reduction of health inequalities, but that doesn't mean that we don't have to consider this. So we have the health equity mainstreaming strategy to go to. So please do get in touch if you have any kind of concerns or you need any kind of support in terms of considering these health equity or health inequalities. So now this has been basically the theory behind all this, behind the subgroups, but it might be still difficult to imagine how this works in practice. So this is why we invited Dr. Sophia Brady and Dr. Mackenzie Fong, who are research fellows at the Newcastle University, and they are part of the ARC Northeast North Cumbria, and within that the Prevention, Early Intervention and Behavior Change research team, and they're going to tell you or give you an overview of a couple of their projects to show you how these kind of methodological topics actually work in practice.
Hi everyone, my name is Dr. Sophia Brady. Thank you for inviting me. I'm going to present some research that I did. I think it was the end of 2023 actually. This work was done as part of the Innovation for Healthcare Inequalities programme, which is shortened to INHIP, which was a collaboration with the Health Innovation Network, which was formerly the AHSN, lots of acronyms, sorry, and the ARC, with myself, Dr. Steph Scott and Dr. Jen Portis at Newcastle University, with the colleagues at the Health Innovation Network. So the aims of the programme were to address local healthcare inequalities experienced by deprived, ethnic minority and underserved populations. So this specific project has quite a wordy title, as you can see, but basically we're looking at the experiences of ethnic minority and underserved groups having NHS cardiovascular disease health checks in the northeast of England. So we can move on to the next slide, please. So hopefully this kind of applies to some of the methodologies that Kathleen mentioned before that you guys specialize in. So I'm hoping that it's kind of relevant to some of you. So it is a qualitative project, but I won't go into too much detail about the qualitative methodologies because I'm not a qualitative researcher anyway. But there's a kind of mention of how we developed interventions from this. There's obviously a behavioural science element and some implementation. There'll be a kind of section on how we implemented the findings of this project at the end as well. So next slide, please. So first, a bit of background. Apologies for the size of this. It's not gone that big, but basically a bit of background in case people don't know about cardiovascular disease. So cardiovascular disease, or CVD, is a term used for a group of diseases that include kind of diseases of the heart, blood vessels, and cardiovascular system. So this can include things like strokes, peripheral artery disease, high blood pressure, coronary heart disease, and things like that. They're all kind of put under CVD. So CVD is the leading cause of death worldwide, and it's about over 7 million people are living with CVD in the UK, and it's the cause of 25% of UK deaths, so quite important. And it costs the NHS about £7 billion every year approximately. So the prevalence of CVD varies. But people living in more deprived regions are much more likely to die prematurely from CVD than those in the least deprived regions, not surprisingly. So the North East and North Cumbria has got the lowest healthy life expectancy and highest level of inequalities in any region in England. So you can expect that the burden of CVD will probably be quite high up here. So the mortality rates of CVD are also particularly high in the North East. So kind of giving a bit of background and rationale for why this project was needed. So although the mortality rates are decreasing nationwide, they still remain higher in the Northeast, as you can probably see from some of the from this like infographic. So within the Northeast, Middlesbrough is an area particularly affected by high CVD mortality rates, and this region also has high levels of deprivation and greater inequalities. So kind of honing in on why we specifically targeted Middlesbrough as the area where we wanted to conduct this project. So next slide, please. So according to the NHS website, NHS health check it's a free checkup of your overall health, can tell whether you're at high risk of getting certain health problems such as heart disease, diabetes, kidney disease, and stroke. So if you're aged between 40 and 74, you should get a invite for an NHS health check, and you should have these every 5 years. So if you are in that category and have not had it, then I think you can contact your GP and ask for one as well, because there has been shown that the invitations don't always come out, and there's also been variable uptake of these interventions amongst the general population, and particularly those people who are in more deprived communities or ethnic minorities. Uptake does tend to be lower. So what does the heart check, the health check involve? So they do things like they measure your blood pressure, height, weight, waist circumference, check your cholesterol levels and blood glucose, and then they ask you some questions about your medical history, such as then smoking, alcohol, and physical activity levels. And they put all of these together into like create a score. So it's a CVD risk score, which is a score that indicates your risk of developing cardiovascular disease in the next 10 years. So that's a bit about the check itself. So next slide, please. Thank you. So the aims of this project were to explore the experiences, facilitators, and barriers of underserved groups engaging with these health checks in Middlesbrough, and then from that to co-design some solutions to facilitate greater engagement with the health checks, specifically locally, but then hopefully things that could be rolled out or developed further regionally and then nationally for these underserved groups of people. So next slide, please. So a little bit about the methods. As I said, we used a qualitative approach. So we did focus groups with various different groups of participants, and a total of 45 people participated. And we did most of them face to face in settings that were local to and familiar with the participants, in order to kind of create a more relaxed and kind of approachable atmosphere. That was something that was quite important. So we chose, as I said, Middlesbrough because it's got particularly high levels of deprivation and high rates of CVD. And it is quite an ethnically diverse population, specifically, especially, I don't know how much you know about the Northeast, but the Northeast is not necessarily known as being the most ethnically diverse, but Middlesbrough is a pocket in that which is a lot more diverse. In terms of recruitment and the study population, we wanted adults living in Middlesbrough, so from a variety of underserved and disadvantaged backgrounds. So we particularly were looking to get people who were migrants or asylum seekers. We had a specific interview which was just with these professional migrant doctors and health professionals, so they can get the perspective of people in the healthcare, but also have got from a kind of disadvantaged background. And then there's a high number of kind of South Asians in Middlesbrough, so we recruited those as well, Black Africans, Eastern Europeans, and some underserved white British groups as well. Okay, so next slide, please. So as I said, we conducted focus groups using a semi-structured topic guide. We just wanted to know about people's interactions with health services in general, if they knew what cardiovascular disease was, if they'd heard of the health checks and their experiences having them, if they had had them, and kind of personal experiences, learning about what their barriers and facilitators have been attending, specifically NHS health checks, but then also health checks in general and their interactions with the health services. So in terms of analysis, we did a framework analysis using something called the EAST framework, which was developed by the Behavioural Insights team. So the EAST framework, so EAST is an acronym. So EAST stands for ease, attractive, social, and timely. So these are like the 4 pillars of the framework, and we kind of used in our analysis, we grouped the codes and the themes into these 4 elements of the framework. So how easy were health checks, how attractive, social, timely, etc. So next slide, please. So this is a very quick overview of some of the findings. So as I said, yeah, we identified the sub-themes and then put those back into the framework. And so I'll go into more detail about each of the 4 pillars of the framework. So first I'll start with how easy they were. So next slide, please. So this is a bit about the ease. So making these CVD health checks easy. So a lot of the things that came up were to do with how easy it was to access a GP appointment, waiting times, language barriers, which particularly affected those people where English was not their first language. What is cardiovascular disease? That came up a lot. And what is a health check? So these are just 2 quotes, one from the white British focus group and one from the Black African focus group. So I'll give you 10 seconds to read those. So I think we'll move on to the next slide now. There's we've got a few quotes. So yeah, the second kind of pillar of the framework was how attractive these CVD health checks were. So things that came up in this one was how gender appropriate services were. For example, one of the things that came up with potentially specifically among the focus group, which had just female participants, was that they want to go and see a female health professional, and sometimes they don't get that choice. But it's their preference, and they don't want to speak to a male. Other things that came up were to do with the attitudes of receptionists and different staff in their GP surgeries, and how kind of culturally competent these interactions were. So a lot of them didn't find that they had particularly positive interactions with these staff. And then this kind of thought of having shared decision making. A lot of the time they thought that it was not a 2-way decision, some of the decisions that they had about their health. So not talking specifically just about health checks, but just their general interactions with their health professionals in the UK. So I'll let you have a quick read of these quotes as well. Okay, and then on to the next slide. So third, we've got social aspects of these health checks. So a lot of this kind of talked about, so a lot of things that came up in this were some kind of suggestions for how to improve things. So wanting to have more support within community settings, towards just kind of healthcare in general. Things about tokenistic engagement, feeling over-researched but underserved, and then the wanting of using kind of ethnic minority health professionals as health champions to try and encourage kind of more interaction with the health services. So again, 2 more quotes here. Feel free to have a little read of them. And then the final pillar on the next slide was just about the timeliness of the health check. So again, the same things are coming up about the waiting times. A lot of the people who we spoke to had caring responsibilities, whether that be for being a carer for an adult or for children. A lot of the people we spoke to did non-9 to 5 jobs, so working in sociable hours. So being able to get a GP appointment was very difficult with their lifestyle. So needing more flexible appointments and just more flexibility. So these are two final quotes for you to have a quick read of. And then I'll go on to the co-design elements. Okay, so next slide, please. Okay, so these findings informed a co-design process where local partners were used to help shape and develop health checks suited to kind of these cultural and linguistic and kind of more kind of specific needs that we found from those interviews. So the co-design element was mainly run by our collaborators at the Health Innovation Network, because they had some really strong connections with the community leaders and the local community in Middlesbrough, which was incredibly helpful. I think it was probably the most helpful thing as to how this co-design element of the project worked and why it was quite successful. So if you want a few more details on some of the co-design elements and the background of it, feel free to use this YouTube link or scan the QR code. And because the Health Innovation Network made a video based on this project, so there's more detail in that. So next slide, please. So these are just some of the. So they had a day. The Health Innovation Network ran a day with the community leaders, whereby they kind of brainstormed some ideas for what interventions could be co-designed based on the findings of those interviews that I said. So these are just some of the ideas that they had. So these were not all implemented, but these were all the ideas that they had. So there were things in like social marketing, like trying to increase it, like local social marketing to try and so people knew more, one about CVD, about health checks and about what they should do. And there was also the idea of creating some resources that are more kind of specific to certain cultures and also translated into different languages. There was the idea of training the workforce, so there was more kind of cultural competency. So those people who are healthcare professionals or working in, for example, GP surgeries. There was the idea of having more capacity within the communities, as I said, having health champions, more access to translation services at healthcare in different healthcare environments. And then finally, this community outreach element, so using assets within the community, which were already there. So a lot of these communities that we were speaking to had these assets, but they just weren't being used enough. That was the feeling that was coming out quite a lot. So these were some of the ideas. So next slide, please. So these are some of the actual activities that kind of came out of as part of this research. So initially there was the idea of the CVD outreach training, so it included the creation of some tailored resources, staff training and things like that. So I think in the end they delivered 29 health check outreach sessions. Some of these were held at Teesside University, health buses. They used community health champions, and they actually did health checks at Middlesbrough Football Club, which I think is that picture in the middle. So trying to go to different places to try and catch different groups as well. So I think in the end there was over 500 extra health checks that were done in total, and then people were then referred to their GP practices if there was anything that came out of it that was worth having another check. So they also did some awareness training. So community leaders recorded a debrief video, which is also on that video on a few slides back as well, and led some local social marketing, some like resources were developed and distributed, and consequently, the year the project was running in Middlesbrough, there was a huge increase in the prescription of drugs that we know to reduce cardiovascular disease risk. So I think, as I said before, a huge benefit of this co-design approach to implementation was that this helped improve engagement from these specific groups in health checks. And it actually, I mean, as you can see, it kind of made an actual tangible difference, which was really good. So final slide, I think it is now, and then I'll be quiet. So yeah, overall, the project identifies some really key barriers to health checks in underserved communities in Middlesbrough, and I think it was just that really hands-on approach to implementation. It led to some really positive outcomes. So thank you very much for listening. So if you've got any questions, feel free to send me an email. So I'm going to have to head off a little bit early, so feel free to send me an email. But yeah, thank you very much.
Thank you very much. The presentation was really interesting. I mean, you've done a very similar project to something that we did here. I just wondered if the work continued? I mean, have some of the things that you've obviously highlighted there, have they been fed back and implemented in routine clinical practice now?
I think, yeah, this is something that we hoped to be an aim of the project, just to do with the tight turnarounds. A lot of those co-design solutions had to be done outside of actual clinical care. So a lot of the health buses and stuff, it was run by like pharmacy students and like sports science students. So we couldn't actually, in the turnaround we had, implement it at kind of general practice. But I think as a consequence of some of the things that came out, for example, some of those resources I think have been sent into general practice, but like not everything we were able to do was able to, but some of the things I think have been implemented long term. That is something that we are kind of trying to keep pushing on with as well. I know that the colleagues at the Health Innovation Network are really keen to try and keep that going.
Yeah, I mean, it'd be great. I maybe contact you offline, because I think this new, the NIHR Health Inequalities Challenge that's come out. So I'll contact you separately about that. It's really interesting. Thank you for the talk.
Yeah, of course. Thank you. Thank you so much.
Thanks, Sophia. So my name's Mackenzie. I'm a research fellow at the Applied Research Collaboration North East North Cumbria, same as Sophia. I'm a dietitian by background, and most of my research does tend to be in nutrition, obesity management and prevention. So this is a little bit different from my bread and butter, so to speak, but still very much fits within the different methodologies that Catalin introduced earlier. So this study is a randomized controlled trial of a 12-week telehealth remotely delivered exercise intervention for people with peripheral arterial disease living in deprived areas. So yeah, just a similar slide, just kind of showing the elements that of different methodologies that have gone into the intervention design and the research itself, which I'll pull out as I'm speaking through the project. So just to quickly talk about the study inception and I guess how the project started and it came to come across my desk. So basically, Dr. James Prentice is an anaesthetist at Newcastle Hospitals Trust, and he basically noticed a gap in care in his clinics. So he started to notice that people with peripheral arterial disease weren't receiving the treatment for certain symptoms that is NICE recommended. So he had this idea for this intervention that he wanted to deliver, and he kind of had a vague idea of how he wanted to run a study and what a study might look like, but he wasn't too sure. So he engaged with us at the ARC, came with the idea and kind of said, I'd really like to develop this and ultimately get some funding for it. And we were very lucky that we were successfully awarded some funding to conduct this work. So the actual work itself, a very quick bit of background. So this study focuses on peripheral arterial disease, or PAD for short, and it results from a progressive narrowing and hardening of the peripheral arteries, which prevents adequate blood flow, especially to the lower limbs. And it's estimated that of people in the UK over 60, 20% of people will have PAD, which is quite significant. Again, with that health inequalities angle, prevalence is significantly higher among socioeconomically disadvantaged populations, and these populations tend to experience much more severe and advanced versions of the disease, and it usually leads to increased disability, amputations, and mortality in that population. So the primary symptom of PAD is something called intermittent claudication, which is characterized by discomfort or cramping or really, I guess, painful lower limbs during physical activity. And typically it goes away once you stop walking or once you stop doing exercise. But basically, this really affects people's mobility, if you can imagine, really reduced cardiovascular function, and ultimately it impacts quality of life quite significantly. So the current NICE guidelines recommend supervised exercise as a first-line treatment for claudication, also coupled with lifestyle modifications to prevent further cardiovascular events. So that's things like looking at smoking cessation, changes made to diet, weight management, physical activity. And while we know that supervised exercise has been shown to improve walking capacity, cardiovascular health, and overall quality of life, in reality, supervised exercise programs, as I'm sure we all could guess, are quite largely unavailable and unfunded across the UK in the NHS. And then you also have to think about this particular population. So people with PAD face additional barriers to accessing supervised exercise sessions. So they experience really low self-confidence in walking. Some people can literally only walk for about 20 steps before they have to sit down. There are financial constraints in more socioeconomically advantaged patients, so that kind of really prohibits them from accessing things outside of the NHS that are privately funded. So our study took place during the COVID-19 pandemic, the very height of it basically in 2020 to 2021 is when we started to look at doing this study. And as you're aware, there was a really significant disruption to the delivery of traditional face-to-face care, but also interventions such as exercise programs. And it kind of really emphasized the need for accessible approaches for people who just simply couldn't, for a whole bunch of different reasons, attend in-person appointments. So telehealth presents a really promising and cost-effective approach to traditional care methods, and it can mitigate those physical, financial, and structural barriers to accessing care in person that more socioeconomically deprived people face as well. It's really important to understand patients' experiences of using these virtual interventions just to ensure that these interventions are feasible, acceptable, and they're actually working as intended. And this becomes even more important for socioeconomically deprived patients who, as I mentioned, they might find it even more challenging to engage with interventions, but particularly digital interventions. This population statistically are more likely to have poor access to the required materials and equipment, so potentially don't have any computing devices at home. Perhaps internet is either patchy or they have to share it with others, and it doesn't feel, all that private. They tend to have poor digital skills and digital engagement. It's quite, something that I found a little bit unusual when I started to do this study, but studies that actually explore the feasibility and acceptability of virtually delivered interventions are really, really lacking, especially in socioeconomically deprived patients. So enter the TextPad program. So James, the consultant anaesthetist, he'd work with researchers at Northumbria, and he had teamed up with HealthWorks, which is a community health charity based in Newcastle. And he also worked with the Newcastle United Foundation to co-develop a health behaviour change and exercise program for patients with peripheral arterial disease. So at the beginning of the program, patients in the TextPad group were provided with plain English materials about PAD, its causes, and its management. They were encouraged to perform unsupervised walking for approximately 30 minutes, 3 to 5 times a week, and they were also given a little Fitbit device. A big part of the program was that every week they got a phone call from one of their dedicated health trainers from HealthWorks, and that happened over the course of the 12-week program. The telephone sessions were tailored very much to that individual. So they addressed issues that included things like smoking cessation, alcohol use, diet, weight management, but also a bit more holistically, mental well-being and finances as well. During these sessions, the health trainers drew on lots of different behaviour change techniques, so including things like information on health consequences, social support, goal setting, problem solving, self-regulation, restructuring the environment. And then the final bit, and I guess a really big part of the intervention, was twice a week, participants attended exercise sessions that were delivered over Zoom. If the participants didn't have the equipment that they needed, that was provided to them by the research team. So if they needed a tablet device or a Wi-Fi box, that was given to them. So drawing on the methodologies that Catalin highlighted, we can see that behavioural science was a core component of the intervention. It's also a very complex intervention, given that the program addresses several aspects of health behaviour. The program was delivered in a community setting by a health charity, so that's another kind of moving piece of the puzzle, and that the intervention has been adapted to the needs of people with PAD as well. That's quite complex. In this study, we wanted to find out three main things. So, is the TextPad intervention feasible? Is it acceptable? And is it a promising way to improve people's health? And I'm going to focus much more on the acceptability arm of that, but we'll kind of lightly touch on feasibility as well. In terms of initial effectiveness, that bottom outcome, that's something that's still sat with James, so I can't speak to too much about that, unfortunately. But in terms of feasibility, we wanted to look at patient screening, eligibility, recruitment rates and retention rates at 12 weeks, and also intervention adherence. So were people actually turning up to these sessions, or was it just of no interest to them? And you can really see that we've drawn on those principles of implementation science again, because feasibility and acceptability are really core components of implementation outcomes. So very quick overview of what we did. So this was a pilot feasibility randomized control trial. So we just wanted to see, I guess, do a little tester of a trial to see if it's something that we could scale up and do a full effectiveness evaluation later on. So we recruited patients from the Northern Vascular Centre at Newcastle Hospitals Trust. They did baseline assessments, which included like a 6-minute walk test. We looked at their dietary intake, and we asked them lots of additional questionnaires about the impact of PAD on their quality of life. They were then randomised on a 1-to-1 ratio to either be in the TextPad group, which is there on the right-hand side. So they were encouraged to do kind of regular walking. They were given a Fitbit. Then, as I mentioned, they had those weekly telephone calls and those bi-weekly Zoom exercise sessions. Or they were allocated to the walking group. So this is kind of what NICE guideline recommends. So they were encouraged to perform unsupervised walking for 30 minutes, 3 to 5 times a week. They were given a Fitbit as well. So again, just drawing on the methodology, we've applied a trial design to this. So clinical trials, we've got that element here. And then after 12 weeks, when we repeated the 12 weeks assessments, we also did some interviews, and that really allowed us to explore barriers and facilitators to delivering and receiving the intervention, so we could understand the contextual influences on implementation. So again, really drawing on implementation science there. In terms of the findings, the feasibility findings haven't been published yet, so just a bit more on the acceptability, which, as we know, is a really core component of implementation. So we ended up speaking to 9 people in the TextPad group, 9 people in the walking group, and we had 15 males, 3 females. We also spoke to 1 male and 2 female health improvement practitioners who actually delivered the intervention, because we wanted to understand what their thoughts was on that, and they hadn't previously delivered a virtual intervention before. Everything previously was face-to-face, so it was really important to understand their perspective on that. So overall, people had really positive experiences of the TextPad and walking programs. The remotely delivered, the Zoom exercise sessions were much more convenient than traditional face-to-face sessions, although some people say they really miss that sense of community you get by attending in-person sessions. People said that having enough involved didn't really influence their experience of the program. Some people even kind of make jokes that it was Newcastle and not some other football team. I don't know. I don't follow football, but apparently that was, of no consequence to them. Many did perceive benefits to their well-being. Something that the TextPad participants said that they really wanted was more interaction with other participants, that there was a missed opportunity for social support and sharing experiences. And then the walking group said that they would have really liked their step data to be monitored and fed back on by the healthcare team. They just kind of felt they did it, it went into the ether, and then they didn't get anything back. Again, I've got some quotes which I'll read out quickly for you. So this is from someone in the TextPad group who was very appreciative of receiving the care. He said, "But if I hadn't gone to this program, I think I would have done something drastic. If it wasn't for you and the research that you were sitting willing to do, I would have been gone now." So this really, really meant a lot to people. They just felt really, I guess, invisible and yeah, not cared for previously. And then this, again, from someone in the TextPad group saying, you should have a group like once a month or whatever, so we can all sit there like in a circle and introduce ourselves and say, well, this is actually happening to me, like yourselves, but I want to ask each and every one of you a question, if that's okay. How did you manage this, and this? Where in my eyes, that would be a boost to people because they know they're not the only one that's suffering from that and never actually getting any help the same as me. In terms of the technology, which we're really, really intent on looking at, most people were amenable to using the tech. No one was kind of vehemently against it. Everyone was happy and open to using technology. But some people reported they weren't confident using the technology and they had to go to their family or their friends or even the health work trainers to actually get that support. There was the sense that they were just kind of given the equipment, rushed through that induction kind of stage, and there was very little information to how to actually use the tech. The health work staff said they actually really enjoyed delivering the sessions remotely. They were happy to provide additional tech support to those who needed it as well. So again, this person in the TextPad group said, but I'd say maybe they should get an induction. I was just given a Fitbit, the tablet, and they assumed that you knew how to use it, which I did. It's a good assumption. Maybe they judged because of the way I talk. I say there's room for improvement there because there was one guy every week across the first 5 minutes of exercise. He couldn't sync with his internet. He couldn't do this. He couldn't do that. And then the health practitioner said that was probably the only challenge I found was some of the participants really struggled with the technology and some of them were starting to get like frustrated. And that's when I would have to go around to their house and show them in person how to do it. That was the only issue that I had really. So they were really going above and beyond to provide that support. And finally, we did look at their acceptability of being involved in a trial. We didn't get a huge amount of data on this because, to be honest, everyone was just really easygoing about it. And they were kind of just like, yeah, it was fine, didn't bother me. So there was very high acceptability of the trial procedures. The process of randomization was acceptable and perceived to be fair. The length of questionnaires was fine and they were all understandable. So we didn't actually have any issues with trial procedures. So in terms of recommendations, I have to say this hasn't been fed back yet to adapt the intervention because some of the other bits of the evaluation is still ongoing and we want to get everything together before we go back with recommendations. But basically, our three big takeaways are to improve patients' experience of their ability to gauge with the intervention that requires use of digital technologies. Intervention deliverers really need to think about what digital skills and digital literacy do these patients have. It's not enough just to give them the equipment. That really needs to be that embedded support, maybe like an induction program, for example, at the beginning. Secondly, it came through really strongly from a number of TextPad participants that they really wanted a support group. So that's potentially something that could be embedded into a future version of the intervention. And then similarly for the walking groups, they wanted some kind of sense of accountability or monitoring of their activity data. So again, that's something that healthcare providers can keep in mind for the future. And just to say that this kind of I guess recommendations and making recommendations for adaptations to the current program aligns with implementation science because adaptive implementation is a key principle of implementation science that emphasizes that reiteration and refinement of interventions. Thank you, and I'm super happy to take questions and likewise connect offline over email.
I've got a question. Hi, thanks for the presentation. Really interesting. I mean, I think these things are always difficult. I mean, the group I'm particularly interested in are the people who declined to participate, because I think it was about 27 on the slide that you showed. Did you get any further information on why they declined to participate? Because that really hard to reach group are when we're designing interventions like this, if we could understand better why people say no, we could obviously build that into the design of the study or the approaches. Did you do any work on that?
Unfortunately, I have to say the study was set up in a way that it was James who was doing all the screening and all that kind of thing. And my understanding is that he didn't systematically collect that information. But my impression is that I should have mentioned this work was kind of like a pre-surgical prehab kind of intervention. So getting patients fit for, most of these patients go on to have stents, for example. So they were considered a surgical population. And I think a lot of them weren't eligible because of the scheduling of their surgery. I think that was the number one reason in that it was a 12-week intervention and actually they were having surgery like in the next 3 weeks. So that's my impression. That was the main reason, but I totally agree with you that it's so important to look at the people who choose not to opt in. And that's something, I think we need to keep in mind when we do these sorts of feasibility studies, is even if someone declines, having a systematic way of collecting that data.
Yeah, thank you.
So just to flag up an online resource, if you would like to learn more about behavioral change, behavioral science and behavior change, there's a workshop series that I've been developing. So there are going to be 6 sessions, currently 2 available. So it's about the most influential behavioral change theories and the determinants of behavior change and the effectiveness of interventions. So you can access this at this link. And I'm going to pass it on very quickly to Mark, who's going to tell you about an upcoming subgroup event in collaboration with clinical trials and the health economics subgroup.
Yeah, just click through it. I think it's.
Yeah, I'm just going to put it all up.
Yeah, that's brilliant. Okay, so one of the key bits I think we've noticed with the subgroups is connecting them all up. So as a consequence, the health economics team and the clinical trials team have sort of got together, and we've got a meeting on the 14th of August. If you register, you can go to that URL and you'll be able to register. And essentially, the health economics team are going to talk about health economic evaluations alongside clinical trials. And that's it. Thank you.
Perfect. Thank you very much. So, and then finally, and most importantly, how to join these subgroups. So if you want to join any of the subgroups, you can join more than one. You can join all 10, which is obviously not so feasible, but whichever you're interested in. And obviously this can change over time. So you can drop out of one and then join another one if you wish. Obviously this will follow your project plans. Please get in touch through the email address. So try not to get in touch directly with leads. If you get in touch through this email address, we will be able to allocate your request based on obviously capacity and expertise as well. So we would like to have some control over this because a lot of our leads are volunteering their expertise and time to this, so we don't really want to overwhelm them too much. So, and in terms of choosing which one to go to, it really is up to you and where you are in your project and what kind of support you need. So don't feel that you need to join. You can still attend these subgroup events or training sessions. But if you do join, that means that you're probably going to be kept in the loop a little bit better, and also you will have a say in where the group is going, what your training needs are, and they can provide you with training and all of these kind of things. So there are advantages to that. And then finally, I just wanted to flag up this hashtag implement equity. So if you do have any kind of conversations around health equity on social media, please put hashtag implement equity in it, because we are collecting all these responses and we would like to see what kind of conversations are going on and where we can help people.